very interesting case studies that you previously presented to the group. So in terms of our agenda for today's webinar, we are fortunate again to have our wonderful friend and colleague Lauren Harden, who's the Director of Complex Care at Mercy Health System and who's been a regular faculty member for this learning collaborative. And Lauren will be reviewing a framework for putting together care teams and focusing on updating shared care plans and sharing the care plans as well. And then we'll have a chance to hear from each of the communities regarding the case studies that you presented previously. So that will be the format for the webinar. One of the things that you all have helped us do is develop a framework for the work that we do. And we've put together a box diagram that shows the different areas where you do your work. And we're developing tools within each of these content areas. So for example, using tools to document the person's story, goals, and care team. That's where the Camden cards that you all have used and frankly helped us refine, and eco mapping and other tools for engaging people come into play. But the place where we'll be hanging out today on the webinar is the development, implementation, and monitoring of the shared care coordination document, because we've heard from those of you in the pilot communities that that's an area that you'd like to do a little deeper dive on. So without further ado, I will at this point again thank you all for your dedication and your participation, and I'll turn it over to Lauren Harden, who again is our wonderful colleague and friend in this learning collaborative. So Lauren, thank you for being with us again, and take it away.
Thank you, Pat. It's wonderful to be with you all again today, and I'm really excited to hear your stories about what's happened since we were together last in person. So you've gone through a tremendous amount of learning in the last year, and what I see with my own teams and having been in this work for several years is this part can start to be the really exciting time when you look back and see what's happened with the patients that you intervened with, what changes are you seeing, and then what are the exciting ways you can take what you've learned and integrate it in a system that continues to stabilize hard patients. So Pat showed you a beautiful diagram going through the pathway of the different things you've learned. You've learned root cause analysis and how to review a record and how to build a team, how to look at data. You've learned echo mapping. You've learned how to work with the Camden cards. You've learned how to work together as a team. What we're going to focus on today is how do you develop, build, house, and maintain a shared plan of care. And what are some interesting ways to think about that in the future? Because we don't want this just to be a one-time intervention. What we want is to really build an infrastructure around complex patients where they remain stable. And we're linked together in a shared team to really meet patient and family needs. So we're going to start by hearing some case review, and the people that are, each person that's presenting is going to talk about a case that they started last spring. They're going to describe their care team formation and composition, who was actually part of their team, what was the schedule of meetings for the team, did they develop a shared care plan, if they did, where is the care plan housed and how is it managed and updated, and then how are you currently linking the plan in the cross-continuum team. So whether it's your collaborative team that's working directly with the patient, or if you think about eco mapping, who are the other people that may not be meeting with you that may want to be connected to that plan? So without further ado, I'm going to turn it over to Rutland, who's going to talk about their case review and answer these questions.
Sure. Can everyone hear me, I hope? This is Sarah Narkowitz from Rutland.
Yep,
Sure.
you're unmuted, Sarah.
Okay, thanks. Just wanted to check in before I just delved into this. So this is a case that one of our community health team case managers has been working with, and should be familiar to those of you who've been participating in the collaborative since the beginning, because I think we've talked about this case in our collaborative training sessions. So it's a 47-year-old female who has MVP for insurance, and it is her migraines and fibromyalgia that has been the diagnosis that sends her to the emergency department on a very frequent basis. As you can see, in 2014, she had 89 visits to the emergency department here at Rutland and 4 inpatient visits to Dartmouth. She does have a major depressive disorder and 3 previous suicide attempts. So in, I'd say, March and April, Sharon was beginning to use some of the tools that we were learning about with this patient, and beginning to have conversations about what are the root cause. And so initially we kind of knew there must be something going on that is deeply buried, and so initially said, you know, mental health issues, and that she does have a daughter with addiction issues. And at the table, Sharon was able to rally her primary care provider, Sharon as a member of the community health team, members of our emergency department, and the challenging connection with the neurologist over at Dartmouth Hitchcock. Again, the primary reason for these repeated ED visits was for her migraines and getting a protocol treatment plan that was developed by Dartmouth at the time. And so every couple of days, I guess it would wear off and she'd be back in the emergency department. So Sharon did develop a shared care plan. I'm looking at it in front of me. It was one of our earlier renditions, done in pencil, and it's dated April 2nd, where she identified Sherry's contact information, her primary care provider, a care coordinator at the primary care office, and the treatment goals, the patient goals. So treatment goals were better symptom management of migraines that would result in less ED visits, and more consistent treatment or adherence to having behavioral health counseling. The patient's goals were similar, which was to control the headaches and less ED visits. Strengths were identified that increased communication within Sherry's medical providers and support team was identified as a shared strength, but the potential barriers were family dynamics with a daughter, a death of a sister, who she was never able to reconcile with. So on this shared care plan, which Sharon has kept in her file, and I think she gave one copy to Sherry, to the patient, she has noted on here there's been multiple changes in the care team. So one of the critical elements is that her neuro treatment has transitioned from a Dartmouth site to a local site here in Rutland, and that the behavioral health support in her primary care practice has changed, her care coordinator there has changed, and there's a number of others on the list. So it goes to show that there is this constant transition of staff as they come and go. They're not going to be there forever, and they need to understand this woman's kind of past and history and her challenges. Over the summer, there was not a whole lot of movement in how things were going with this patient. But then in September, there was this transition of the provider from Dartmouth to Rutland, and it initiated a change in our emergency department where her treatment plan was changed so that less medication was being provided. And at the same time, we had the benefit of having a psychologist join our team and providing her with some support. And it was discovered that there is an underlying psych issue with some childhood trauma, so that she's developed a relationship with this psychologist and has been being able to address this issue that I think in the past hadn't been identified and addressed. I think as a summary, it's important to note that we completed one full calendar year where she had 71 ED visits versus the 82, so that's a good thing. And most of those visits have lessened in the last quarter of the year. So I think our discoveries around this patient is it takes a while to, figure out what the patient needs, what the team needs to do to engage the patient in change, and to really kind of create, a full support for her. And I think, we're feeling positive that things are now going in the right direction, whereas over the summer it felt very stalled. I think I'll stop right there. And I don't know if anyone else on our team, did I miss anything? I'm looking at Meredith, the social worker who works with Sharon as well.
I do think the utilization of the psychologist was an added layer of support to the team itself to sort of look at the team's level of engagement and responsiveness to the patient's identified needs, as well as just developing some more consistent communication in terms of how that response is going to be made in regards to the patient's care. And knowing that there was that continuity and the patient was aware of the team's level of involvement and ongoing communication was actually reassuring for the patient.
So we certainly, just beginning to benefit from the use of a shared care plan, and that we certainly in Rutland chose some very difficult patients to do this with, but we are feeling like we are making progress, and having the additional support from the psychologist has been a huge benefit, especially just sitting down with the care team staff and beginning to talk about root causes and how to address those.
I want to commend you. I'm so excited by what I'm hearing you report. First of all, looking at the case review from April and then to now, so in typical care management, or a lot of things about the way typical care case management intervention is structured, you would look at this woman and see, oh, migraines, diabetes, COPD, okay, we need a diabetic education program and COPD. What you did is you really did really great root cause, and then you continue to build team even in the face of really challenging things. So in the medical realm, you identified headaches as root cause. In the psychiatric realm, you identified the depression, and suicidality is very important. In social, you identified the daughter and addiction in a previous review. And then you also really quickly went right to really important root causes in the system. So you called out treatment for the headache and the fragmentation between the neurologists at Dartmouth and the other providers. I want to commend you for getting the neurologist at the table. How did you do that?
A lot of perseverance on Sharon's part. it was challenging. I think that was probably one of the biggest challenges. And I do think that the change in provider certainly was, an opportunity to enhance that communication, because the communication with a provider outside of the local area just added to the complexity of it for sure.
Yeah. And you had identified in the system issues, a potential that she was being overtreated or had the wrong treatment plan in the ER, and also that she had the lack of mental health. And what makes me very happy to hear is really underneath all of this probably is the trauma, and she's connected now to treatment for the trauma. I think it'll be exciting for you to watch what happens with the headaches, because I see that in the chronic abdominal pain population and the chronic migraines with very high incidence. There is a real medical component to it. It's not, so people really do have headaches or abdominal pain, but underneath it, it's so common that there's a current domestic violence or a significant trauma history that hasn't been dealt with, and when people start dealing with it, we see really big gains beyond the medical treatment and reduction in their visits. So you have a shared care plan. Is Sharon the one who maintains that and keeps that going?
Yes, she does, and she did admit, it really hasn't been updated in quite some time, other than noting the new providers and the change of names. And so it could be time to kind of reassess the shared care plan and as to where things are today. Sharon knows this information. She noted here that the patient really enjoys working with her new neurologist and is looking forward to decreasing her meds and potentially starting some Botox treatment. So really, I think who knows what her relationship was with the Dartmouth team. So it sounds like this could be a positive thing in her favor.
That's great. And then how often does the team meet? Do they get together once to make the shared plan, or is there an ongoing meeting structure for that team?
We have not evolved into an ongoing meeting structure at this point, and that's on the to-do list. But I think it's, starting is to have it down on paper. And even in the last month, we've talked about our challenges are sharing this piece of paper in a means that is meaningful, because if we, fax it, hand it out, where is it going to go? Our hospital-owned EMR doesn't have a great place to put it for people to know it's there and to look for it. So those are certainly areas that we need to work on in this next year. I think locally we've been encouraging people just to sit down and fill it out. There's been this hesitancy, I might do it wrong, and we're saying there is no right or wrong way. So we're trying to increase the comfort level, and the more people that we can engage and just trial one, do it, give it to the patient as a starting point, and then next time give it to the primary care provider and the patient. So we're dipping our toes into that, and hopefully that we'll see it spread.
That's great. And what I see in the work here too is a lot of people think, oh, if we start doing this, we have to meet every month or every quarter, and it's really important to kind of define it around what is going on in the case. And a lot of times what I see here is once we have that shared conference, we may not need to come together again for another year, as long as someone's driving the intervention and communication consistently after that. So if you have someone like Sharon that's watching, and when there's another, let's say something happens and she breaks her leg, or she gets a pneumonia with COPD and then goes on a vent, and then she has a lot of COPD stuff, then you might pull everybody back together again, because it's helpful to readdress that change. But as long as you have someone following and driving it, everybody knowing about each other alone, just that act sometimes has a tremendously positive effect for the patient, because like you noted, it's not uncommon for there to be a lot of turnover in the care team, or for the care team to be completely unaware of each other. So it'll be real interesting to see what happens from here. So it's not necessarily the technology that has, like the perfect technology where you get pop-up alerts and HIE, embedded care plans. It's the principle of coming together, understanding the real root cause, being committed to communicate with each other that really starts to make the difference for the patient.
Well, it's confirming to hear you say that, because I think, just getting it down on paper was valuable in itself. And I know that Sharon, from her viewpoint, can watch what's happening in the emergency department through looking in our EMR and noting if there's any of those visits that seem out of the norm. So she does have a good viewpoint to just kind of keep her eyes on what's going on, even though she might not be having direct contact with everyone.
Well, I want to commend you, and I'm very excited. You can tell I have a big softy heart. I'm so pleased that she's connected to probably the most important root driver of many years of high-frequency use, and that she's connected to help for the trauma. So I just want to commend you for your effort. Great job.
We'll let Sharon know, or we all will. Thank you.
So next up, we have Burlington. Is that right? No, St. Johnsbury, sorry.
St. Johnsbury, yep. So I think we have a group together with Pam Smart. Can you guys hear us? Let us know if we can hear you.
Yes, and now we have Gidget Doty with us, who is the lead person on this case.
You want to? Can you mute Rutland for us for now?
Oh, yep. Thank you for the reminder, Sarah.
Okay, take it away, Gidget and Lou.
Hi, this is Gidget. We had presented before a 58-year-old female who's now turned 59. She was duly eligible for Medicare and Medicaid. That was the population that we selected. So again, she had several medical diagnoses that impacted her care, but primarily, like Rutland, the psychiatric diagnoses seemed to be the main reason that she was going to the emergency room. It was more related to the anxiety versus the COPD when she got down into the notes themselves. She actually had an admission for an overdose and a problem for an abscessed tooth as well. So we're going to stick with our original root cause of anxiety. It'll be the next slide. Originally at the table, we had the primary care office, our community health team, which actually includes our local hospital, our local mental health agency, Northeast Kingdom Human Services, and then her Suboxone provider, which was an hour out of our area. So now we have at the table better resources. We have the primary care office, our community health team, including the hospital, Northeast Kingdom Human Services, and a local provider for her Suboxone. So she's staying in the area. Originally, this patient was very difficult to reach, would only return phone calls periodically, and had trouble getting to her appointments because of transportation. So next slide, please. Now at the table, we've identified the members of the team, which was so important to us coming into this, because even though we knew she saw someone over at Northeast Kingdom Human Services, we didn't know who that person was. So I think a big piece for us were the shared releases and identifying everyone that was actually on the team, and then understanding that there were resources available inside those particular teams that we hadn't actually tapped. So at the primary care office, we have embedded mental health that we were able to put this patient in contact with that was not impeding her care with Northeast Kingdom Human Services, more of an augmentation with our health coach at the office. And then we were also able to get her into a local provider for her Suboxone, which has made it so much easier for her to make those appointments. The other thing that we were able to do was realize that her appointments with Dr. Jedlowski for her COPD, she was actually going to a town outside of our service area for those appointments, when with just a little bit of coordination we could get those scheduled locally and increase her compliance. So originally we had put this patient on the list because she had 12 emergency room visits prior to being part of this collaborative. Since we started this in May, she's not had any emergency room visits. So even though we have a shared care plan with the case manager in the emergency room, we actually haven't had to put it to use because we were able to get the patient connected with all of these other resources that are embedded in the things that we already have going, so that she's been much more compliant. Her COPD is actually being treated and is manageable now. Her anxiety is being treated. She was able to meet with the health coach in the office. Even though she's vaping, she's actually agreed to set a quit date. So she's much more stable. We were able, inside of our organization, we have dental services, so we were able to get the abscess tooth taken care of. So since we involved her with this collaborative, we've been able to kind of tie up all these loose ends for her and really help her manage the disease processes that she has, which has in turn really decreased her anxiety. We still have current barriers to her stabilization. You know, she's still very difficult to contact, and she does no-show, although she's much more apt to reschedule at this point. The biggest barrier that we had with this patient was that she had such anxiety that meeting with the group itself and doing a team meeting was too much for her. So we had to go into this with kind of a different mindset. You know, we use these tools for a lot of different patients, but with her we had to do it kind of backwards. So we made her the center of the team, and then with the primary being myself, we would meet with each member of the team, and then we would come and report back to her so that she was more comfortable, still felt like she was participating, but it didn't cause anxiety for her to meet as a larger group, you know. And the same was true for many of the interventions that we had, meeting with the health coach at the office. Instead of doing that as a group with one of our local agencies, our health coach was able to meet with her on an individual basis and try to help deal with some of those things. So we, even though it was a little unusual, we found great success with it because she's not had any overdose attempts and she's not had any emergency room visits at all since we started the collaborative.
Awesome work. I'm so excited.
I'm excited too, and what was really unusual was I didn't actually appreciate how well we had done with this until we actually started looking at the numbers and went, oh my goodness.
Yep. And there's some really important themes in here too. So if I'm going to go through the root cause a little bit. So if you look at root cause for her, you look at, wow, look at all these diagnoses. There's a lot in the medical realm. And so a traditional care management pathway might say, okay, we need to, you know, first focus on quitting smoking and COPD patient education and things like that. What you did is really utilize that root cause framework to get down to what was really the driver. So you went, you captured the medical information in the psych realm, you identified the anxiety and the substance use as drivers, and that was so important because anxiety, what we see a lot here is it's a very big driver with visits for people with COPD. When you think about smoking, smoking is often something people do to deal with anxiety. And then they develop COPD and then they try to quit smoking, but they don't have anything to replace. How do they deal with their anxiety? So it's a very important thing to address as a root cause, equally as important as the disease management. You also identified the transportation in the social realm and the root cause, and then some really significant system issues, access, having her privacy and anxiety and being the group respected, the resources that she needed organized in a way that works for her, And what's fascinating is you were able to look within the system by doing that cross-continuum team identification and linking. You were able to find more resources without necessarily adding costs. The resources were already there, but once you linked with each other, you had a much greater capacity of what you could offer to the patient. So who holds the shared care plan that you have? Is that one person? Is it in the primary care office? Where is that primarily held?
It is shared between the primary care office and the hospital, the local hospital.
Great. And did the team meet once, or did they have a regular meeting, or how have you structured that?
That is kind of flexible with us. We met once. And then we have actually a monthly meeting where we meet to discuss cases like this, and we present certain things on a regular basis. So I think we talked about her at 2 of those meetings that we had already scheduled, but we meet at the same time every month to discuss certain things like this anyway.
Great. And is the care plan on paper, or is it in technology, or how did you house that?
It's on paper and it's scanned in, and it would ideally we would like to have one that we could type into and change periodically, but technology's been kind of a struggle with us here because there's about 5 different EMRs that we're dealing with.
Yeah, yeah. And having dealt with, I'm dealing with a company and implementation around 100 hospitals across the country, and I like the scan version. It really works. It's fast.
It works for us. Yeah.
It really does. And, we have every kind of version you can imagine. So how often are you going to change that plan, do you think? Is it something that you update every time you meet monthly, or is it something that once you've got it, you might address it, but you may not need to change the content of it every month? How do you deal with that?
Again, on an as-needed basis, we definitely don't have to talk about it on a monthly basis. I think once the shared care plan is in there and the team members know that it exists, it's much easier to do it on an as-needed basis if the patient's had a change. And again, all of the members of the team are now paying attention to what's happening with her, so if she does turn up, we know how to communicate with each other. And I think that's another important thing, is that the communication between all the members of the team has gotten so much better because of this.
Yeah, I completely support that. I have there's a very complex gentleman that we've been taking care of here. He's in his 50s, and he just died yesterday. He very complex medical, HIV, Hep C. He developed very serious blood dyscrasias near the end of his life, so that he was constantly having nosebleeds. And he really was hospice, but he didn't want to have hospice because of his overall trauma history. Had just, I don't have permission to share the details of his history, but just really, really traumatic childhood trauma, and, long history of abuse, and not having his personhood respected. So when he was actually physically going through a dying process, it was very important for him to continue living. So he had multiple providers fragmented across multiple systems. We did a shared care plan, and the providers were frustrated. They wanted him to pick hospice because he was bleeding, and he was coming into the ER like every other day, to get packing or get, blood transfusions. It's like, we can't undo this. It's going to go forward. But by coming together and sharing the story, everybody started to understand, okay, he really did want to live. So it was our job to link together and coordinate as much as possible to help him live until he died. And once everyone met each other, then they developed a community on email, so protected email. So you can't just do this with anybody. You have to set it up where it's patient HIPAA protected. But then whoever was the person who he met with and something significant happened, that person would just send an email to the group. And everybody felt like they were in the story. So I have actually seen him for a year and a half since that first conference, but I felt like I was part of the care team in the story because I continued to hear what was important. If my skill set was important to bring to the table to help the outcome, then we would call together a conference or I would throw in. But if not, it was included in the circle that surrounded this person. And everybody wrote back and forth to each other and acknowledged him and acknowledged each other and what that coordination could be. So something simple like an email community can actually continue that connection. And it really saved a tremendous amount of time and really improved his outcomes because we were consistently on the same page with each other and with him, even though his case was very, very complex. So, excellent job, St. Johnsbury, and look at the difference that you made in this person's life, and also from a quality perspective, from a personhood perspective, and then also when you look at cost and system overuse, what a difference that you've made. So let's move on to Burlington and hear what Burlington has learned.
All right. Okay, let me just. So I think we have Kathleen Audi, and I'm also going to go ahead and unmute Cybele Joy in case she wants to chime in as well. Can both of you let us know if we can hear you?
Yes, I'm here. This is Kathy.
Great. Cybele, can we hear you? Okay, well, Kathy, why don't you go ahead and get started, and I'll see if I can work with Cybele to get her unmuted.
Okay, so Floyd is now a 54-year-old individual. He has Medicare and Medicaid now, so VCCI is no longer involved, and SASH is. So I've been working with Floyd since June of this year. We have had, since I've been on board, we've had 4 care team meetings. Mostly that was due to just like the staff turnover, people leaving, people coming on board, and we felt it was important for all of us to get together and meet. And the last team meeting that we had with Floyd and his family was December 15th, and we actually held that in the home. We have developed a shared care plan, and Cybele and I are meeting next Monday to update it from the meeting we had on December 15th. And that's just, I think we kind of felt like during the summer things just kind of have stalled with Floyd, so we all wanted to kind of meet and kind of figure out who is kind of willing to do what. So since I've been here, I believe Floyd has only had 1 ER visit. He still has a lot of people involved, SASH, the Community Health Center, the Division of the Blind, and Floyd has agreed to do a guest visit at the Adult Day program through VNA this coming Friday. So hopefully, if he does like it, we're hoping to address some of the social needs that'll get him out of the house, and I think also address his nutritional needs. I would say probably the thing that we're still trying to deal with as far as health-wise is still trying to stabilize his blood pressures. Seem to be a continuous issue that we're trying to deal with. I know together as a team, we do a lot of the emailing back and forth, like myself and the SASH wellness nurse go into the home once a week, and usually we do updates through the team through the email, which I think has been very helpful and beneficial. As far as the sharing of the care plan, I think we're still trying to develop that and figure out where is it going to be stored, and who to share it with, and all of that.
When you started working with Floyd, what were the reasons that he was hospitalized?
So I think it was my understanding that it's just, I think it was due to missed medical appointments, trying to stabilize his diabetes as well as his blood pressure. And so I think, I think that we've all been trying to work as far as, just like his medications and then just having everybody involved. I know the Division of the Blind have gotten, like he has a blood pressure cuff and it talks to him because he's blind. So just trying to incorporate some of those things. I know we also monitor his blood pressure, like we have sheets at the house, and a family member records those. We just actually started doing that, and then I'll scan them in and email them over to the community health center.
Great. So from a root cause medical perspective, he's got multiple medical and some important barriers that need to be paid attention to with the blindness and the amputation and the access. What kind of psychiatric root causes might be going on for him?
So I think we're trying to address that currently. I think at the last CURE meeting, I think Sibel was going to work on trying to see whether we could get a therapist into the home, not only for him, but maybe the family as well. I think, obviously, with him losing his eyesight has been a huge issue for him. I think he's just trying to, how does he fit in? Where does he go? How can he still enjoy his life with not, his eyesight? And hopefully the Adult Day program, when he does the guest visit, he'll enjoy doing that, because I think that'll be a huge piece, and it'll give him the socialization as well as just meeting new people.
That's really critical. So we see that a lot with younger people who've had significant losses from multiple medical chronic disease. Addressing that grief and loss is so important, and you've tapped right into the social root cause as well, which is that loss of socialization and meaning and relationship. So very, very important. And then you started to mention some system root causes. So one part might be the ability to report information. Another part might be access. What other system root causes have you found with Floyd?
Again, I think that's just maybe the understanding of his, I think all his like health issues. I think I think the vision has been a big piece. Like he goes to, he has different doctor's appointments and stuff, and then, I think it's just trying for all of us to be on the same page as far as, what the doctors are giving him information and then what he's understanding. I think the biggest issue for him is, he still believes that he's going to be able to get his eyesight back through some sort of surgery. And I think it's just all of us working together and trying to be on the same page and getting the same information and just.
Are you still there, Kathleen? And that makes sense. So you mentioned that you've had 4 care teams. Are you still there?
Yes.
Okay. I think there's an echo on my end now. You mentioned that you had 4 care team meetings, and is the care team from the community care team, or does it also include his doctors and providers in the hospital?
So it's been like myself, the stash wellness nurse, the nurse at the community health center, the nurse case manager, Sibel at the community health center, Dr. Warrenkin, and we have invited the case manager through the VNA, and then also the person through the Division of the Blind.
Great. And do they each have that care plan then in their agencies, or how have you handled that?
We have not figured out how we are going to handle that. We're not sure if we're going to share like just a paper copy with them or if it's going to be electronic. I think we're still trying to figure that out as a team and where it's going to be stored. And
Great. And is there one person in charge of maintaining the plan or alerting the team to next times that they need to meet?
You know, I think for the most part, it's probably been myself and Sibel trying to work together. And we actually, the other nurse case manager that was involved, she just recently left not too long ago. So I think we're still trying to figure out. Sibel and I are going to meet next Monday to update it from the December 15th, and then figure out where to go from
Lauren
there.
and Kathy, can you hear me? This is
Yeah.
Sibel. Okay, finally. Sorry about that. Took me a while to get connected. I just wanted to add a couple pieces, if possible, to this particular case. Kathy has done a phenomenal job really kind of pulling people together and keeping this patient kind of on the forefront of you know, the notice of the medical home. But this patient I recently got involved with because a nurse case manager left. And just to mention, I had done one home visit, only one, and this was a while ago, and walked into a situation that was incredibly chaotic. You had a patient with multiple comorbidities who had advanced disease states because he wasn't taking care of any of his medical needs at all. I mean, including amputee, as we said, advanced eye disease, and also at this particular stage, because of not taking care of his health for so long or not having the resources to do so, he's one step away from dialysis. And amazingly, his diabetes is now under control. The A1C has come down, but you know, the advanced complications are there. When I did go in, and this was passed on to another nurse case manager, there were just so many different pieces. He didn't have anybody in place. He didn't have any services in place, but some of that was because he didn't want them in the home. So it really took a lot of relationship building and trying to get people back in and back involved with this patient. And I think Kathy's done, even though she came in late, she's done a phenomenal job with that. Now the piece is, and where this, and correct me if I'm wrong, Kathy, where this got a little stagnant is that the family's involvement and knowledge of the disease state and what needed to happen, you know, wasn't there. So I think that's where we started pulling care team meetings together, which were interesting because we had them in the home, we had the family present, we had the patient present. You can imagine there might be some high intensity and emotions there. And I also was able, I work for a community health center where I have some pretty dynamic doctors and medical providers who actually will come with me into the home. So they accompanied me into the home as well as the nurse to kind of really talk about the ramifications of just his disease process and state, what the family felt they understood, what they could do, and then what they thought they could, you know, contribute to the care plan from here on out. And they were pretty honest, too, with saying we can't do it all. So I think the beauty of this process is probably pulling all of these pieces together and having one person kind of be that person to keep everybody in communication. And Kathy has done that not only with this patient, but with a couple other really complex ones at the community health center that I'm working with her on. So I just wanted to add that one little piece.
That's fabulous. And Kathleen, you really need to acknowledge and really commend you for that, because that can be the most challenging thing, is herding all the cats and linking them together and then not losing faith, especially when there's turnover. It's a really important thing, and it's very, very commendable as well that you went from the multiple hospitalizations to just one ER visit. To me, that's an indicator that the person feels they have trust in someone that they can connect to, as well as excellent interventions for better coordinated care, better disease management. So great job. We're going to move on to the next slide to go over a couple of principles. Some of these things refer to the case review, but I just wanted to give you a couple of things to think about. When I'm looking at embedding plans, so I work with hospitals and home care and all kinds of people all over the country because Trinity is so big. And so one of the first questions I'm asking when we're looking at are we going to embed these plans, are we doing it through technology or not, is what's the scope of influence? So, for example, if I'm working with a community agency, do I have a really good relationship with the hospital and the PCP where we can get that embedded in their technology? If I don't, that might be too big of a hill to climb. So then I'm looking at what systems already exist that I can integrate in. In some markets, they have the health information exchange where you can build a plan right there that everyone can see. In some, there's nothing, and it's much more effective to look on paper. So I look at what's the scope of influence, and then what resources already exist. I told you the story about the patient where we communicated on email. That was just as effective as the pop-up plan that's embedded in the EMR that pops up every time the patient comes in. So I don't want you to think that paper is lesser than technology. It just depends on the culture you're in and what you have access to. And then I also think about where will the plan actually change the outcome. So for example, I was working with, we get a lot of very, very hard psychiatric diagnoses here. People with fused personalities, not guilty by reason of insanity, really, really odd manifestations of long-term trauma and psych, self-mutilating, all kinds of really hard things. Not everyone needs the plan. I look at what's the driver for that person, how are they hitting the system, and where does that plan need to pop up or exist so that the people at the point of care have what they need to do the right thing for the patient. So for example, a specialist might only need a call or might only need to sit at the table for one care conference, but really doesn't need that ongoing plan. They just need to know who they can call if the person comes back in and they don't know what to do. Whereas the ER might need it all the time, as well as primary care. So I look at where is the driver of that person's frequency in the healthcare system, and where does that plan need to be integrated so it will change the outcome. Next slide. So triggering events to revise the plan. We asked everybody who's managing the plan. I think it's really helpful to have one person that's watching it all the time. One of you mentioned that the person is looking on the EMR and noticing when there's a change in ED visits. That's a really great thing to do. We have different reports built that automatically print out a daily list of where people have been. You can get real techy with it, or you can just physically look in the EMR. Equally as effective. But having one person that's kind of driving that, I think, is really helpful. When it's everybody's job, it kind of becomes no one's job, and nobody knows who's supposed to call who. So I think it's helpful to have one person identified. The interval for revision, I think, needs to be at least annual, but then it depends on what's going on with the person. We try to build that main plan as something that would stand for a year, because we don't want to, we're following 1,300 patients and adding another 5 to 20 a week. So we don't want to build something that we constantly every week have to upgrade the care plan, but we're every day managing their care. So depending on what your resources are, you may want to have the interval for revision driven based on the patient condition. So a basic plan identifies the key root causes, the cross-continuum team, the things that you're going to focus on, the things the patient cares about. And then when you would revise it would depend on, did they have a new acute episode, and does that significantly change the core plan, care plan, in a way that it's worth going through the revision and getting that embedded wherever you have it embedded again. I do think when there's a transition in level of care, it's an important time to pull everyone together for sure. So like the gentleman that I spoke about at first, he was in a very acute treatment phase because he was constantly bleeding and needing intervention. He had a transition in level of care where he could no longer take care of himself, but he had no one in his life, and he was living alone. So he was pretty much living in the ER because he would, get sick, he was too weak to walk, and he would call 911. So we had to have another care conference then and develop a new plan of care because it was a significant transition in what his environment and needs were going to be. And then I think that setting the expectation for revision is really helpful to do from the front end. So if you're the one person managing, think about how you want to frame that in the care conference. So the way I'll do it typically is I will explain what the shared care plan is and say that this is intended to be a document that we utilize to help improve care and outcomes, that I'll manage that plan, and that the expectation is it will be revised on an annual basis, but anyone in the group is welcome to call if they see a significant event that they think it needs to be revised sooner. So I usually do both and thinking with that kind of work. So we're almost out of time. What questions about shared care plans and embedding them did I not answer today?
So just a reminder to folks, if you're trying to talk and we can't hear you, it's because you're muted. So just press the little handshake button and I'll unmute you. I'm not seeing any questions coming through in the chat box, just a couple comments. I think we might have Pat offer a few closing remarks. Well, we encourage you to, gather any thoughts you have and not be shy and throw out questions either by raising your hand or through the chat box.
Great. So thank you all so much. What an inspiring hour this was to hear the progress you've made. And Lauren, thank you again for just sharing your incredible expertise. I do want to just give you some ideas on next steps. I want to let you all know that 8 additional communities followed your lead and are now participating in the second round of this learning collaborative. And so we'll continue to invite all of you to the webinars for the second round and to in-person learning sessions in case you want to refresh your knowledge, bring new team members, or share your knowledge. So stay tuned for that. You also will continue to have access to our quality improvement facilitators, Nancy Abernathy and Bruce Safran, and you'll also continue to have access to Blueprint for Health practice facilitators to support you in this work. And then finally, I want to let you know that we're launching an exciting new program at your request. Beginning in the spring, we'll be offering extensive core competency training for frontline care coordinators. We'll include sessions on care coordination fundamentals, disability-specific training, advanced care coordination topics, and we'll also be offering training to managers and supervisors, and we'll be doing a train the trainer component so that we can sustain the care coordination core competency training. So stay tuned for that. Start thinking now about whether you'd like to attend. We'll offer it probably in 3 locations, sort of roughly north, central, and south. It's a very ambitious undertaking. We'll be able to train up to 60 people at each site. So keep that in mind. Start thinking about who you'd like to attend. It's for all types of care coordinators, licensed folks, folks who aren't licensed, and we really hope to spread the knowledge through that as well. So, and also I do want to let you know that there's technical assistance on specific tools that we've introduced as part of this learning collaborative that is available on request from our partners at One Care Vermont. All 3 of our ACOs have been supportive and involved in this work, as well as Blue Cross Blue Shield and DEVA and VCCI and others. So lots of support out there. We definitely want to keep the work going, and let us know how we can help continue to support you, because that's our goal. So thank you again. It looks like we do not have.
Yeah, I haven't seen any additional questions come in, and we're at time, but I'm happy to leave the webinar up for a couple minutes if you want to take a few minutes and you have the time before you have to sign off to gather any thoughts. If you put them forward in the chat box, we'll be sure to follow up with you after today's webinar.
In addition, if after you leave the session today you have additional questions or comments, if you post those up on Basecamp, we can get feedback both from your peers and also we can send those off to our expert faculty to get their opinions on it. So I know for myself, I sit here and I get a question 5 minutes after we close. So please post your questions up on Basecamp.
Terrific.
Great.
Thank you all so much. Lauren, thank you. To our wonderful presenters, thank you so much for not only presenting, but for the great work that you're doing out there.
Thank you.
Take care, everybody. Happy New Year.
Congratulations, everybody. Great work.
Thank you, Lauren.
Talk to you soon.
Take care.
Bye-bye.